Hi, hello friends, how are you? Today we have Dr. Paul Trikha from UK. He's a leading knee and shoulder surgeon. We shall invite sir. Uh, we shall learn all the new techniques. Uh, shall learn all whatever we have doubts. We'll clear the doubts. I request everyone please join. So 1 minute, I got one message from hospital. I'll just reply to them. Yeah, hi friends. Uh, hi.
Hi,
Whoever is watching. Hi, sir.
how are you?
I just got a message from hospital.
I hope,
So you are, sir?
I hope everything is okay.
Yeah, all good, sir. So, sir, first of all, I would thank you for giving me this opportunity. Uh, I'm really thankful. So, for the audience, please introduce yourself, sir.
So my name is Paul Trikha. I'm a soft tissue sports knee surgeon in London at the Sharon Clinic and in the NHS at Ashford and St Peter's NHS Trust, and also at Surrey Orthopaedic Clinic. I deal with knees and only knees from all ages, from children to parents and grandparents.
Nice. So, where do you work? Which hospital, sir?
So in the NHS, I work at Ashford and St Peter's in Surrey, which is where I do a lot of my children practice and young sports injuries. And privately, I work at the Surrey Orthopaedic Clinic and also at the Sharon Clinic in London.
So, 3 hospitals.
A few more than that, but they're the major ones, yeah.
Nice, nice. We are very glad to have you, sir. So, shall we start?
Yeah, sure.
Yeah. Sir, what's your opinion on partial ACL tears? So, when do you intervene?
Okay, that's straight into the deep end then. So we're talking about partial ACL tears. So it depends what you mean by partial ACL tears. Is it a single bundle ACL tear? For a lot of your viewers, the ACL in traditionally consists of 2 bundles, and my understanding of partial tears is, for a surgeon, is whether one of these bundles is torn. But in another way, you could say what percentage of the fibers of the ligament are torn. So the answer to the question is how much pivotal instability they have. So if they have pivotal instability, whether the tear is partial or not, the diagnosis is, and the clinical examination is key, and the symptoms of the patient obviously will dictate how we manage the patient. So
if the patient doesn't have any pivoting?
So if the patient's not complaining of instability, then you will obviously trial non-operative treatments, be it with a strong rehab with therapy, regain full range of movement, regain strength, potentially a brace, but if they're not pivoting, they're not giving way, then maybe not. But if they are and they're unkeen on surgery, or they don't do pivoting sports, using a brace and physiotherapy is a good way to go.
So what are the studies saying about partial ACL tears, whether these patients go into a complete tear, or there no strong evidence like a partial ACL tear will probably or will definitely go into a complete tear?
So it depends whether you're defining a partial tear based on MRI. So I use MRI to confirm the clinical diagnosis. So if the patient has obvious ACL instability on exam, be it a positive anterior draw, a positive Lachman test, and a positive pivot shift, whether the MRI scan says the ACL is partial or not, normally won't matter. Because if there's a partial ACL tear and the menisci are torn, or there's chondral injury, or there's a root tear or a ramp tear, the partial bit becomes insignificant because that's not true or real. The clinical diagnosis of a complete ACL rupture, and you're treating the patient, not the scan. If the patient has an endpoint on examination and doesn't have a pivot shift, then the partial tear comes into play. They'll often have increased laxity on examination, but not gross laxity, grade 1, grade 2. And they're the ones, if they have no other intraarticular pathology, you might consider a good trial of non-operative treatment, especially in children.
Okay. So what's your opinion regarding copers and non-copers? I think nowadays there are some set of population, even the patient has got a complete ACL tear, we still advise them you need not undergo surgery. So what's your criteria, like what's your thoughts about copers and non-copers?
So deciding on who needs surgery. So I think for a young person who is sporty and is engaged on pivoting sports, and they've torn their ACL, especially if there's an additional injury, they are going to most likely undergo surgery, and you need to think of a good reason why they're not going to have surgery. If they've had a traumatic injury, complete ACL rupture, play pivoting sports, I think the default is now to perform surgery. Okay. As you get older, as the pivoting aspect of your job or your sports decreases, it then depends on what's torn and what's not torn. So an ACL tear in you, if you've torn your meniscus, the answer is quite straightforward, because you want to preserve the meniscus. So doing an ACL reconstruction to regain stability, protect the meniscus, and therefore protect the chondral surfaces in someone who has instability is a very natural progression. Because as night follows day, an ACL deficient knee with instability will lead to meniscal tears, often irreparable tears, which can then lead to degeneration if these are treated with meniscectomy. So I think a lot of it depends on patients. I don't have an age cutoff. It's more how active they are. If they do pivoting sports or they have occupations that demand pivotal stability, one would be builders, people who work on roofs, firemen, people who need to pivot and have ongoing instability, then they are the ones I would consider for surgery. So who is a coper with non-operative treatment, isolated ACL injury, no objective or subjective instability or minimal, no other additional injuries or risk factors for further injury, and we can talk about which those are, and patients who don't want the operation, you can always try isolated ACLs with non-operative treatments first.
So does obesity make you to operate if the patient has got a complete ACL tear, no instability, and the patient is grossly obese? So you advise them surgery or not?
If they're grossly what? Sorry?
Patient is grossly obese, has got a obese.
That the patient's grossly obese.
Obese.
Okay, so isolated ACL And how old?
30 years.
Okay.
No pivoting, no pivoting. Patient has got a complete ACL tear, no pivoting. He is grossly obese.
And is no instability?
No instability.
And how did he tear his ACL?
Sir?
How would he have torn his ACL?
Latchman is positive.
Yeah, but what was the injury? Was he playing sport?
No, he is not. Just a software engineer. A desktop job.
Okay,
Desktop job.
okay, so some obese people play sport. Okay, so in fact, I have treated many wrestlers and not the big sumo types, but high level heavyweights and even some Indian wrestlers who have instability. It's not a size thing, okay? But the morbidly obese patient who's 30-year-old who doesn't play sport and has no instability is treated non-operatively. He would be a very poor candidate for surgery if he's not complaining of instability.
So don't operate. Better avoid surgery.
Yeah, yeah. You would always try rehab first.
Yeah. So, sir, what are your thoughts about prehab? Few surgeons, they tell a lot about prehab. Before posting the patient for surgery, you put them on physio, get the quads strengthened. So what are your thoughts? Like how frequently in UK you follow this prehab?
Okay, so I'm very lucky in my NHS practice as well as my private practice. We have good, up-to-date physiotherapists who will prehab a patient, be it in a class or in a one-to-one session. I think it's very important not to allow the patient's knee to settle down after an acute injury, to try and regain extension, to try and get a quiet knee. We all know that after an ACL injury, the first several days the knee's acute and inflamed and hot, and wait till the knee quietens down, and sometimes you can get to the patient within 10-15 days their knee is quiet enough to perform surgery. So yeah, I'm a strong believer in rehabilitation, prehabilitation. Most of the physiotherapists I work with you know, do well for my patients and make me look good. So you know, it's a very important part of all knee treatments, not just ACL, to be honest.
Okay. So what are your graft choices? Like you use a BPTB or quadruple ST or tibialis posterior or quadriceps? How do you decide what are your graft choices?
Okay, so that's good. Tibialis posterior, because tibialis posterior tendons in the UK are not used. Okay, so tibialis posterior autograft.
Yeah.
Side. Okay, you can tell me about that. So I do hamstrings, bone patella tendon, and quads routinely. Very rarely, or less than 10%, I will use allograft. So the more higher risk the patient, the more likely I am going to consider other options. So the highest risk patients for me are the young, under 25, the female patient, those with a large pivot shift, those with large meniscal tears, those who are having revision surgery, and those that have a high tibial slope. Okay, for those patients, you want to choose the most appropriate graft, which in a prop forward rugby player or wrestler, that might be a bone patella tendon or maybe a quads tendon graft. In a young, slim dancer, it might be a hamstring graft. Nearly all of those patients I mentioned would probably be supplemented with a lateral procedure, be it a lateral tenodesis or
Lateral extraarticular tenodesis.
yeah, or if people prefer an ALL, anterior lateral ligament repair. But they're the high risk patients, and in that group you should consider why you're not doing surgery for these, and those are the people that you want to consider, and you need to work out what's the graft best choice for the patient. I think most ACL surgeons should be able to do all of those operations. be it a hamstring, a quad tendon, a patellar tendon, and they need to have all three of those options available to them.
So to just summarize, when do you consider bone patellar bone BPTB?
So, um, so you know rugby, sport rugby.
Rugby.
Yeah, the ones,
Yeah.
the patients who are going to, you know, the prop forwards, the pack, the front row, they're going to more likely have quads tendons. You know, people who are going to do quads tendon or patella tendon. Footballers, high-level footballers, I think do better with patella tendon. Nearly always with something lateral as well. Even young girls, the jury is out whether we should be doing hamstrings because they are the highest risk of re-rupture. But if you don't do regular patella tendon, then doing one patella tendon on a 17-year-old patient isn't the right treatment. You should do what's good for you. But what I'm saying is nowadays, most ACL surgeons should be able to do all of them and discuss the options with the patient. You know, if the patella tendon ACL is slightly better in terms of laxity post-op, then maybe that's that graft may come around again. But they will have pain. They will have pain at the front of the knee. That's the downside. And they will have a scar. So some patients may go and have a hamstring ACL instead. So you have to, I think now, in this day and age, you have the patients want to know everything and you have to share with everything. Everyone has an option.
So for people who are into active sports, you advise them BPTB.
Yeah, if you are a sprinter or a winger or a fast bowler, maybe having your hamstrings taken out and reducing your speed a little bit or having hamstring issues might not be the best way forward. The quads tendon is a strong graft. I think the results, the Stability 2 trial is coming out comparing patella tendon with quad tendon actually, or hamstrings versus quad tendon. So we'll have better outcomes on quad tendon soon. But I think it's a very good graft for revision surgery if people don't want hamstrings or patella tendon. Yeah, it depends. If you're a sprinter, a hamstring graft is not good for you.
So you don't use tip post regularly, tibialis posterior regularly.
No, but tell me about tip post. Do you do it?
Very less. Here in India, majorly to, as you said, the patient is into active sports, BPTB, and if it's a just normal patient who does like a desk job, like a software engineer or a doctor or a lawyer or a constable, uh, more or less like a sedentary lifestyle, we advise quadruple ST. If he is into active sports, then BPTB, because the beginner surgeons usually they are not that trained in BPTB.
Okay, fine. So I thought most people in the UK are definitely trained in BTB at some point. So I think it's important that, you know, if you're doing a hamstring ACL and there's some problem with the hamstring, what are you going to do if you can't do a BTB or a quad tendon? Yeah, I don't know whether you have if you have a registrar who just, if my junior colleague has damaged the hamstring or the hamstring hits the floor or it's a very small graft, you know, you've got to have more options, haven't you?
Yeah, do. So we should be acquainted with both the graft harvesting techniques. I do agree. Uh, nice.
So we know, you know, we all know surgeons who will only do hamstring, only do allograft. We have surgeons in the UK who only do allograft. You know, and that's, you know, we know it's got a very high re-rupture rate in young patients. So yeah, in the UK, I think the tide is moving towards ACL surgeons being able to perform all ACL surgery, all graft choices. But your surgeon, when you have surgery, has to have a plan A, B, C, and D. If you only have one plan, you know, the pressure's on. So putting a 6mm graft into a 6'2" basketball player or rugby player is not going to work.
Yeah. Coming to that point, what's your criteria or what's your take on what's the minimum diameter of the graft that you take? It's 7 mm or 8 mm or 9 mm. What do you prefer?
Again, you've got a you know, a 5'2" patient with a 8mm graft is going to be enough. A 5'2" patient with a 7mm graft might be enough. You know, it depends what you're going to do. If you have a small graft in a small patient with a narrow wall and a narrow notch, that might be just enough. You know, you want to try and give her better anatomy than she had first time. You might supplement it with a lateral procedure. You know, it all depends. If you've repaired the meniscus in this patient, they might be braced afterwards. So it all depends on what else you're going to be doing. Okay, so I don't have, in a normal average sized person, I want an 8, minimum 7.5, but I want an 8. That's why the quads tendon's a good graft. That's why the BTB is a good graft. And that's why hamstrings is unpredictable. So, you know, when I do a hamstring ACL, we need a plan B, maybe the other leg, maybe taking something else, you know, to augment, or if you're doing a lateral procedure.
So when do you do a lateral procedure? Like, what is your criteria?
Okay, so this is important, I think. So anyone who's under 25 in my hands gets a lateral.
Anyone?
Nearly everyone.
I wish I should do that.
Nearly everyone. They're the age group with the highest re-rupture rate. All children.
All children?
All children, I do a lateral procedure. Talk about.
You mean all the age groups, like 10 to 20?
Yeah. Even 8 to 20. All children I will do some kind of lateral augmentation on. We can discuss which ones we do. Young, hyperlaxity, obviously, would be a good option. Revision surgery, everyone. People with large meniscal tears. People with high tibial slopes.
Wow, that's a great point to know. Because we are, I really can't generalize this, but in my very short practice, sometimes we run out of tourniquet time. So,
or an ACL. Okay.
So I think, yeah, we need to all pediatric. So you do for all pediatric?
I do, yes. And that in particular.
So you counsel the patient?
Pardon?
You counsel them prayer. Correct. Parents, you counsel them.
Absolutely, more than you could possibly imagine, because the re-rupture rate in children is very high. So we can discuss in detail which children get surgery, but if you're going to do a child's ACL, you've got to be able to use different techniques, different graft choices, be conscious and cognizant of the physis, the growth plates, protect them, and respect them, particularly in the young patients or the ones approaching puberty. This is very important, and this is why those people should be operated on by knee specialists who have experience in dealing with children. It's not any adult for certain. But the tenodesis, the procedure in them will be slightly different, because again, you have to be cognizant of the growth plate and you don't want to capture the joint.
So you do IT band tenodesis or ALL reconstruction?
So I tend to do a lateral LET, lateral extra-articular tenodesis, as my default in the mature patient. In the younger patient, I'll either do something below the growth plate, or I will do a strip of ITB tucked under the lateral collateral ligament, and then brought over itself and tied to it. And my routine lateral tenodesis is a small incision on the lateral side and a strip of ITB under the lateral collateral ligament, fixed in line with the lateral epicondyle behind.
So what do you use? Bio screw or a titanium screw?
For the tenodesis?
Yeah, LET.
I use a staple.
Staple?
Yeah.
Oh, I have never seen someone using staple. Nice, nice. Good point.
Okay, all the studies on lateral tenodesis have been with staples. So people using anchors or screws, yes, the principle is still there. And I know people use anchors because you want to make sure that that tenodesis does not interfere with your femoral tunnel. Okay, so where you place that staple or screw is important because those tunnels, your femoral tunnel of your ACL and the tunnel from your lateral tenodesis, they can coalesce at a point. So I use a staple. I'm careful. I know where my femoral tunnel is. I've got a lateral incision. I can see where the tunnel is. I can see where it comes out. And I want to get the isometry correct. I want to put the position of my ITB in a place that avoids that tunnel, but in the correct place, because you don't want to capture the knee. That's important.
So what is the order? Once you do everything regarding the ACL, then you fix the LET?
No, so I will make my decision on whether I'm going to do an LET often at the beginning. Rarely will I change my mind, but often at the beginning for the criteria we talked about. So I will take the graft and I will do the tenodesis because I do it for quite small scars. And that is possible if the knee is not full of water. So before the arthroscopy, you know, so if I'm going to do the tenodesis, I like to do it, if possible, the harvesting of the ITB, the positioning. I won't fix it until I've put the ACL in, but I'll do the dissection, the diathermy, the hemostasis, all before, and then I'll fix it finally at the end. But once I've prepared the ITB area, I will then do the ACL, check my femoral tunnel, fix the ACL on the femur, fix the tibia, and finalize with my tenodesis.
Yeah, whether fixing the ACL screw is the first thing you do or the LET is the first thing you do?
I will do my LET, but I won't fix it. So I will pass my strip of ITB under the LCL. I will mark out where I'm going to place it. Okay. And then I will do my ACL reconstruction.
Any rationale, any scientific reason behind this? Why you need to do LET first and then put the screw for ACL?
Because the femoral tunnel position of your ACL is more important than your lateral tenodesis.
Yeah.
If you do a screw and then you drill your ACL in a place you want it to be, and then you hit your screw, you have now compromised on your femoral position of your ACL.
Yeah.
Does that make sense?
Yeah, true.
Screw. Whereas the tunnel position, you know, the most critical thing when we as surgeons look at other surgeons' work and looking for reasons for failure, you know, tunnel placement is quite high on the list of issues. So get your tunnel position right. Yeah, that the femoral tunnel position for your ACL is more important than your lateral tenodesis. However, if you're going to fix your tenodesis miles away, some people go very proximal on the femur. That's okay. You can do that first if you like.
Okay. So you can prepare your femur tunnel, you can prepare your tibial tunnel, you can do the complete ACL surgery.
Yeah.
At the end, you feel there is still some pivot. Then you can plan your LET.
Okay, agree, you can, but I put it to you that if you do an ACL properly with a good graft in a good place, it's unlikely they're going to pivot. They shouldn't be pivoting after your surgery. So if I do an ACL, if any of the above, hamstring, quad, patella tendon, and they pivot after the ACL, I'm not thinking that the tenodesis is going to save me there. The problem is what I've done with the ACL. Have you missed something? Have you tensioned the graft correctly? Have you put your tunnels correct? Sky. You know, have you missed the root tear? Have you missed the ramp tear? Why are they still pivoting? So that shouldn't be happening. A tenodesis will not save a pivoting ACL. The tenodesis is to reduce the re-rupture rate in my hands in the high-risk patients.
Okay. So, great, this thing I understood. So, what was you suggesting? Like, first you should do a LET, then you should plan for your femur tunnel, isn't it?
Yeah, so this is my choice. This is the way I do it. I think that, so I will do my dissection. I'll take the strip of ITB. I'll pass it under the LCL. I'll mark on the femur where I would like that to be. Okay. I will attend to any bleeding or hemostasis because we know that area can bleed and cause hematomas. And then I'll go about doing my ACL. I'll check that the femoral tunnel doesn't impinge, or my ALL, my LET position won't impinge on my femoral tunnel. And then I will place my staple appropriately. I won't change my femoral tunnel of my ACL to accept my LET. It's the reverse should happen. Your LET is there to supplement and support your ACL, not the other way around.
Okay. Coming to ALL, do you do regularly the ALL reconstruction, sir?
Not regularly, but I do ALL in people who've had previous LET procedures or had sometimes if I'm trying to avoid some other piece of metal work, or there's something else on the lateral femur, or somebody's used the ITB before for something, then I might do an ALL.
So you do it how frequently for every 10-20 ACLs? ALL.
ALL, no. So 1 in 3 of my patients at the moment get some lateral procedure. 1 in 3 at least. As my patient cohort gets younger, it's probably a bit younger, a bit more than that now. But the younger you are, the more it's likely to be 1 in 2, or if you're under 30, there's a good chance you're going to get a lateral procedure from me. And then my go-to is a lateral tenodesis, a Lemaire, a modified Lemaire procedure. And then if there's some issue with that, okay, then I will consider an ALL then. So ALL happens in my practice, but not LET, more common.
Sir, do you do any extra augmentation for the graft using other, there are many proposed techniques which improve the thickness. If you feel the thickness is not appropriate, you add something to the graft?
Are you thinking such as tape? Or so if you have a small hamstring, you have to have options. And like you say, you use a quadruple semitendinosis. So good, that's a good option. If you only have one hamstring and you don't like taking gracilis, you need to be able to triple your semitendinosis or quadruple it. Okay, but I know some surgeons, well-known surgeons, who just use a double semitendinosis. That's it. Okay, so you've got to make whatever you do work. Okay, and yes, a narrow graft and a big player isn't going to work. Okay, so you should be able to maybe quadruple your semi-T and switch to an all inside. That's important. You've got to, so we talk about which grafts. You've also got to be able to do different techniques, be it AM bundle drilling, medial portal drilling, or an all inside, and be able to switch.
Yeah, all inside will save us because then the bone what we drill will come less and the graft diameter can increase.
Correct. And it will also save you if you have a problematic LET, or because you can move that tunnel wherever you like if you're drilling outside in.
Yeah.
What I'm trying to say is you've got to be able to do all these. You've got to be able to use all the grafts, and you've got to be able to use all the techniques. I think that's very important because if my 14-year-old son needs an ACL reconstruction, the surgeon's got to be capable of repairing the meniscus, definitely, 100. Capable of having multiple graft choices in his toolkit. He's got to be able to do outside-in drilling if the growth plates are open. Or, he's got to be able to do a lateral tenodesis and respect the growth plates. But most importantly, he's got to respect the meniscus to be able to repair that. And I don't think I have strong opinions on this, but I don't think now that the ACL surgery should be the remit of everybody. I think you should be able to do all of these things.
Yeah. So coming back to the partial ACL tears, do you suggest any PRP into the partial ACL tears?
Okay, so for PRP, that's platelet-rich plasma injections. Okay.
Yeah, platelet-rich plasma. Any surgeons in UK following this PRP for the partial ACL tears?
Okay, so you will know that there is no evidence to support platelet-rich plasma in any knee procedure. No evidence. Okay, there's anecdotal evidence to support PRP injections in degenerate knees in terms of symptom relief. But are you talking about using PRP to augment a partial ACL rather than doing surgery?
Yeah.
Okay, so if you're going to do that, how are you going to keep the PRP in the site without you're just going to inject it into the knee?
Exactly, that's my question. How can the PRP will go and stay there? It is not a robo, or we are having some button, we are pressing the button, it will go and stay there. It's just a fluid. It will automatically spread through entire the joint.
Correct. So I'll tell you where I use PRP. I use PRP maybe for repairs that I'm very worried about, big meniscal tears. I will use it when I do a meniscal transplant. I will soak my meniscus in PRP. I only do surgery for patellar tendinopathy, rarely, but if I was doing it in that context, I might use PRP. But I don't use PRP routinely in knee surgery because the evidence doesn't support it. You've got to be able to justify what you want. But if a patient comes in and demands PRP because they've read it in the newspaper and they want it, then you can counsel the patient and educate them.
So what's the role of PRP in early OA knee? Do you, in any surgeons in UK still using PRP for early OA knee?
Okay, so PRP for early OA is not as good as exercise. It's not as good as losing weight, getting strong, braces, orthotics, strong rehab. That is the treatment for early OA. There is no surgical treatment for early OA. There is no injection treatment for early OA. I think we should stop peddling that. I have strong opinions on that, as you can see, but the treatment for early OA is always non-surgical, and surgical includes injections.
Nice. So coming to the meniscal root tears, what's your criteria to repair the root tear?
Okay, so big root tears that are not stable should be repaired.
Any age, let it be 40, 50, is there any criteria, till what age?
Okay, so it depends which root tear you're talking about. And for the lateral root tear, are the Risberg ligaments intact? These things are relevant. But I tell you, leaving a root tear, which is unstable, and doing an ACL is not good practice. But leaving a stable root tear, you can justify, but you need to discuss that with the patients. You have a root tear, it's stable, there's no damage, we've left it, the Risberg or the meniscofemoral ligaments are intact. On the medial side, that you don't have that luxury. If the medial meniscus is off and you're doing an ACL, it's pretty rare, and you don't think the and you're doing an ACL and you don't fix the meniscus, you know, a root tear is equivalent to a deficient MCL. Yeah, you shouldn't. This is, you know, I've worked with surgeons who say, I've never seen a root tear, I've never seen a ramp tear. And I say, well, they've seen you. You might not have seen them, but they have seen you. Yeah, so you've got to be able to fix these.
You're having very good sense of humor, sir.
You know, I think you've got to do what's right. Yeah, you don't want to come out of an operation going, oh, I should have done that. Yeah, so, you know, being able to fix the root and be interchangeable in how you treat somebody. I might switch from a hamstring to an LET, or, you know, I might wake a patient up and go, look, I've added an LET, or I've augmented your graft with another hamstring or something, or your hamstrings weren't great, I've used a different graft. But you've got to consent the patients they've got to be aware of this and understand why you're doing things and be able to justify it.
Sir, what is the criteria when you do partial meniscectomy? See, for meniscal repair, yeah, any young patient, traumatic meniscal tear, bucket handle tear, yeah, we try to repair that. So what is your criteria when you think, yeah, we can do a partial meniscectomy?
Okay, so first thing is there's no such thing as an urgent meniscectomy. If you're going to have a meniscectomy, always try and treat the patient non-operatively. Always.
Always try to?
Always try the patient non-operatively. Okay? If you're going to do a meniscectomy, that means chop the meniscus out. If you are going to do a meniscal repair, then the operation is relatively urgent. So if you take a traumatic meniscal tear, you should be repairing it. The traumatic tear, it happened like that, bucket handle, big flap, and knees fixing back, fairly acutely. And if it's a bucket handle, you want to do that. If your child or yourself had a bucket handle tear, the lateral meniscus, I put it to you, you would want that to be reduced and fixed and repaired and not chopped out. And the patient is admitted and another knee surgeon does the operation, or a surgeon did the operation and he's not capable of repairing the meniscus, he should reduce the meniscus and repair it, or reduce it and leave it and give it to a surgeon who can repair it. Traumatic meniscal tears, I think, should be repaired. Degenerate meniscal tears should be trialed with non-operative treatment, even if they have strong mechanical symptoms. You can probably get away with treating them non-operatively for a while. But meniscal tears are the same. You know, a radial tear in a 19-year-old on the lateral side. You know, I've seen a case today in a 19-year-old elite footballer who has a full thickness, complete radial tear of his lateral meniscus, traumatic, and with a small lateral meniscal cyst.
Oh my God.
So, do you advise surgery? Yes.
Yes.
Okay, even though it's a radial tear, you want to try and protect that meniscus. Okay, now if that patient's 50, are you going to advise surgery?
At the age of 50, no.
What if that 50-year-old has pristine cartilage, injured it on the same football field as the 18-year-old, yeah, and has no damage on the knee, but that was the trauma?
Patient's age is 50, and I think at the age of 50 anyway, he will have arthritic changes.
Okay, what if the scan is normal? What I'm saying, it's not an age thing. You've got to decide on your patients. Okay, and the way I look at that is, for meniscal tears, are they traumatic or degenerate? And the degenerate, we should always probably try non-operative, where possible. Non-operative, it doesn't mean non-interventional, strong rehab. You might use injections to break the pain cycle. You know, a good case there would be a you know, a 55-year-old lady or man with some degeneration who's got a root tear of the medial meniscus and SONC, yeah, you know, a SONC, spontaneous osteonecrosis. If there is degeneration in the knee, you're going to try non-operative treatments first. You're going to get the patient on crutches or use an unloader brace to take the pressure off. That is not a good candidate to go in and refix the root. Yeah, so you've got to work out what the knee is like. Is there degeneration in the knee? Is it a degenerative condition or a traumatic condition? If it's traumatic, then fix it. Be high up the list for surgery. If it's degenerate in any part of the body, you do shoulders as well. I don't do shoulders. Degenerate shoulder, degenerate hip, degenerate foot, degenerate knee. You always try rehab first. Traumatic injury to the ankle, traumatic injury to the shoulder, you know, grade 5 AC joint, ruptured ACL, bucket handle lateral meniscus, you know, dislocated hip or a massive traumatic labral tear or chondral. These are, you want to be at the front of the queue and get your operation. You know, so traumatic injuries are different from degenerate injuries.
So if it's a traumatic young patient, a radial tear, yeah, obviously we need to repair. And if the patient has got a degenerative, there is no urgency in doing partial meniscectomy.
Correct. And you can make patients worse.
So what's your advice for a knee replacement? When do you tell them, yeah, you need to go for a knee replacement?
Okay, so this is, again, there's no such thing as an urgent knee replacement. Okay, so knee replacement is a last resort. Okay, not always, but most of the time, a patient needing a knee replacement is degenerative pathology. There are multiple other things that they can do: rehabilitation, physiotherapy, and maybe more physiotherapy. People say, I've done physiotherapy. Maybe they haven't. You know, maybe they, you know, what have you done? How many sessions have you had? Do you do your exercises at home? Do you understand your condition? Do you understand what arthritis is? Do you understand what the pain is, what's happened, and how to manage it? Once you counsel and educate the patients on treating the patient without a knee replacement, you know, you can go quite far. The patients just need to understand, you know, and from a surgeon's perspective, we're pretty bad at explaining that to them. We're pretty bad at treating patients from a non-surgical point of view. But I think for a knee replacement, have you tried painkillers? Do you understand your pathology? Have you done exercise? Exercise is good for OA. That, you know, one of the main things people say, oh, don't do exercise, stop running, stop doing this. This is not true. The other thing, fixed flexion deformity is not fixed in OA. You can regain the range of movement with good physiotherapy and understanding. Often they may need us for pain relief or an injection or something to help. You can use braces. Unloader braces are very good. We've done some publications on this looking at OA for grade 3 and 4, and it works. A lot of people who have got various OA in particular do well with using an unloader brace. And your pain should be bad enough. You do not want a knee replacement for grade 1, 2, or 3 osteoarthritis. It should be grade 4. It should be grade 4. The best results for knee replacement are in patients with the worst knees. The worst ones are who have the knee replacement too early.
No, we have to do, yeah, as you said, I agree. We need to do for at least a grade 4 where the knee is completely damaged, where both the medial and lateral compartments, even the patellofemoral compartment is involved, where the patient is on oral medicines, but still there is no relief. Already she has gone to multiple doctors. Difficulty in doing daily routine activities, difficulty in walking, where it is hampering the daily routine activities. I think then we need to advise.
Correct. You know, patients are led very easily. If someone has a good knee replacement, my neighbor had a good knee replacement, I wanted a good knee replacement. You know, it's like, this isn't right. You know, you have to, when you do do you do knee replacements? You do? Okay. When you do,
yeah, I do very less. I do very less.
but do you tell the patient there's a 10 to 20% failure rate?
I tell around 2 to 3%.
So we know that at least 10 to 20% of patients are dissatisfied after knee replacement.
Yeah, that is there. That I tell them. Yeah, dissatisfaction rate is definitely around 20%.
So, if there's 10 people in the room, I say 2 of them outside are going to be dissatisfied. It could easily be you. Make sure you've tried everything else. You do not need a knee replacement. Knee replacement is part of the treatment for some patients, but the non-operative part is key. Because if you do a knee replacement in a patient who's never had physio, never done exercise, how will they rehab post-op? How will they achieve full extension?
Exactly.
The key to all knee is full extension. Yeah, that's the key. If you have a quiet knee and full extension, you probably never need us for anything. Yeah, so that's the quiet knee and full extension. That's what you need.
Yeah. Thanks, doctor, for giving your valuable time.
You're
I
welcome.
think we had a live for at least around 50 minutes. We'll join again.
Okay.
And I'm telling you, really, this is a very wonderful talk. I can tell from bottom of my heart, for all the young graduates or people who are just doing their MS or DNB, they can watch this multiple times in their practice. It will definitely help. It has got enormous information from the great surgeon, great knee surgeon. I'm very thankful. We'll catch once again, sir.
You're more than welcome, and you're more than welcome to come and visit if you want to. So
Definitely, if you provide me for some fellowship or something, yeah, I'll be very happy to join you.
okay, well, we'll see about that. Look, thank you for having me. I really appreciate it.
So yeah, we can talk this thing and again. So how can the young surgeons from India come to US? Sorry, UK. What is the way for fellowships?
So look, it's quite difficult, as you know, and you have to send multiple applications, and getting your first job in the UK is difficult, and particularly if you've never been here before. Coming on a fellowship and watching is very straightforward, but coming on a fellowship and learning the techniques and hands-on is quite difficult. So you do need to get lucky. You do need to keep persisting. And I know there are some Indian societies that do offer UK fellowships. ISCTA, I think, is one of them. But my fellowship in Surrey is on the Royal College of Surgeons website. It's often booked up a few years in advance, but that would be a good point to have a look on, a good place to start. And yeah, I think that would be, it's very competitive,
Sorry?
It's very competitive, as you know.
Yeah. Nice.
Okay, well, have a good evening. Have a good weekend, everybody.
Thank you, sir.
Thank you.
Yeah. Yeah.